I'd like to invite Dr. Sumeet for his talk on diagnosis of viral endothelitis. And meanwhile, Sumeet, you can also discuss on overall types and patterns of viral endothelitis to cover up for the first talk. Thank you, Sumeet.
Very good morning, everyone, and thank you, Praful sir and AIOC for accepting this IC and giving me opportunity to talk in front of all of you. So, as I said, we'll be talking about viral endothelitis. Viral endothelitis, in fact, endothelitis is a great mimicker, and many diseases can present as endothelitis. Let it be bacterial, let it be toxic, or the viral. Majorly, we'll be talking about the viral etiology in this IC here. So when you see this kind of a cases all together, they all look same that what is happening to it. And when you have three more added to the picture, it becomes more confusing than helpful. So how do you deal with that? So we'll try and make it as simplified as possible. So in general, whenever you want to classify endothelitis, we classify into the four different stages, four different types. The very first is the linear, the another is sectoral, disc shape, and the diffuse. The name itself indicates that this is all because of the shape with which they are presenting. Either they are linear lesions or they are sectoral, or they are so diffuse that they are not keeping any limitation of any boundary. So just to show you pictures here. Now this linear is what exactly? Is it the Descemet fold that you are seeing? So linear here is the keratic precipitates that you are seeing. The lesions on the endothelium, they are in the linear manner. So we are classifying this as a linear endothelitis. Similarly, sectoral one, they are in the one part of your cornea, either superior, inferior, central, wherever. This is again classical of HSV though, but it can be with the toxic endothelitis. This picture could be there. It's a deciform keratitis which involves part of the posterior stroma and the endothelium as well. And the last is diffuse, which is more dangerous, where the entire endothelium is affected and you don't have any borders as such of your endothelial lesions. Now why this is all of concern? Simply because you see a corneal infiltrate, you are unable to diagnose. You can simply go and scrape it off, send it to your microbiologist. Within 24 hours, you have a diagnosis. With the endothelitis, you cannot do something like that because the lesion is on the posterior side of the cornea, not on the anterior. So we'll be talking about the three main types and the three main etiologies of the endothelitis. The very first is the CME endothelitis. Now CME endothelitis, why it is important? Because as per our normal routine teaching, we consider CME is a disease of the immunocompromised. But the exception to that rule is the CME endothelitis, which can happen even in an immunocompetent individual. Now, the largest study published was from the Japanese population, and they reported 109 cases, and they list out the certain factors which are high risk factors for your CME. Why you should know that? Because you are seeing a case where you are suspecting an endothelitis. If the patient has undergone corneal transplantation, putting steroids for long term, and locally immunosuppressed, not generally, locally immunosuppressed, he could be suffering from the CME endothelitis. Now you see these 9 pictures, all of them look confusing to you, but very important here, you need to see the keratic precipitates and how the patient will present you. The very classical description of your CME endothelitis keratic precipitates is they are coin-shaped lesion. C4C, they are coin-shaped lesion. Of course, there will be corneal edema because endothelium is in the shock post-endothelitis and the pump function is not going on as it should. There is mild anterior chamber reaction. You need to know that endothelitis will always be accompanied with your uveitis. And of course, there is ocular hypertension, again a very important factor. Now, why it is so, we'll come to that later. How do you diagnose? Suppose clinically you are seeing it for the first time, it becomes difficult to comprehend all this picture and make it a clinical diagnosis of it. So you have some modalities available like a polymerase chain reaction. It's a test which you can do with your aqueous humor, or you can do a ELISA test for the CME antibodies. In vivo confocal microscopy in anterior segment OCT. So confocal microscopy is very sparsely available, but OCT I think most of the practices have. So OCT will show you, is it linear, is it coin shaped, how big it is, how much area it is involving. So you are seeing a case of keratotic precipitates, uveitis, you are suspecting endothelitis. ASOCT becomes a must modality to document that what is happening to your endothelium at the endothelial level. And this is just for you all to remember. The confocal microscopy gives a very classical aula morphology of the cells of the endothelial cells in cases of CME endothelitis. So all these are very important features. Now, as I said, the risk factor is a corneal transplantation done, and along with the corneal transplantation done, your patient is on topical steroid for the long term. Now this patient is coming to you with some kind of a reaction which is shown here with the arrow. A very first thing that will come to your mind, this is a graft and this may be a rejection, which all of us need to be worried about. And since the rejection needs a different treatment than a CME endothelitis, but at the back of your mind you should have idea that this small coin shaped keratotic precipitates could be even a CME endothelitis and not the rejection. So of course you need to do ASOCT, if possible confocal. If these lesions are not responding to your topical steroids, then your aqueous tap and the PCR becomes must to diagnose that you are not looking at CME endothelitis and rejection. Another feature you need to look is intraocular pressure. Like any endothelitis, like I said, it will come along with the uveitis plus trabeculitis, and it will lead to raised intraocular pressure. So again, you want to differentiate between are you looking at the rejection or are you looking at endothelitis. Please do check intraocular pressure. CME endothelitis, HSV endothelitis will present with the higher intraocular pressure than other reactions which mimic that. Moving on to another one, HSV endothelitis. Now this is a very classical virus which behaves very differently in the epithelium, in the stroma and in the endothelium. And in the endothelium it can cause all types of endothelitis. It can cause diffuse, it can cause deciform, or it can cause even linear. Again, a classical appearance of keratotic precipitates. ASOCT is must in such cases. Again, diagnostic modality to be very sure, the viral culture, PCR or the ELISA are very important diagnostic modalities. Compared to all, this is a very common disease, HSV, which present with the endothelitis along with uveitis along with the raised intraocular pressure. So you need to add systemic antivirals along with the steroids to treat this. Coming to the last, VZV endothelitis. In zoster endothelitis, of course, it will be a little larger coarse capes compared to the HSV, and this is a very classical lesion. So if you see a patient along with sectoral iris atrophy or old sectoral iris atrophy and patient coming to you with the repeated complaint that I am having redness pain, they may not be recurrent attacks of anything else other than the VZV virus. Again, you need to do a ASOCT because it is a documentation tool, and the very important, the diagnostic modality is PCR. So the point to be taken here is that when you are looking at the endothelitis, it could be CME, HSV or HZV. The very best that you can do for such cases that when you do aqueous tap, send for all the 3 PCRs. Many of the labs do all these 3 together, but if you write it specifically, you may miss the diagnosis because sometimes they do mimic each other as well. So when you look at all these 3 and try to think about it again, just give it a time, see them again and again, you can easily diagnose clinically itself that you are looking at the endothelitis. It could be CME, HSV, VZV, and that diagnosis very well can be made on the slit lamp examination itself. So looking at this lesion and thinking about the differential diagnosis of viral endothelitis is very important. So it can be associated with the other differential diagnosis like toxic, bacterial, otherwise as well. PCR is the best diagnostic modality that all of us have. Recurrence is risk factor in all 3 cases which you need to counsel patient for. Early diagnosis in the treatment is necessary in such cases because simply till you are not treating the endothelitis adequately, the endothelial cells are dying out there and you may get the patient with complete endothelial decompensation post endothelitis. So this is something as an emergency we need to treat as early as possible when you see the endothelial lesions. Thank you all for the patient listening.
Thank you, Dr. Sumeet, and that was really a wonderful talk. You covered the initial part also. So, since we want this to be more interactive, any suggestion, any question from the audience, or any real life practical scenario that you have encountered for such cases?
So to describe, since you asked my own case here, so I had a patient of full thickness graft, and it was a second time done graft, and first time it was rejected. So and patient presented on the 6th week with redness, congestion, pain, everything, photophobia. Staining was negative, but I could see the AC cell reaction. KPs were very linearly arranged, and I could not think about a diagnosis of any endothelitis. I treated patient with the steroid for 3 to 4 days, because for me the patient of the rejection is coming with the rejection than anything else. It took me 4th, 5th day to see patient again and realize that he is not responding at all, and I had to do a AC tap. On 3rd, 7th day the diagnosis came that what I was dealing with was basically HSV, because patient was on steroids even for the primary rejection and for the second graft. So even as a cornea surgeons we do miss. So it is bound that if you are unable to get the treatment or get the outcome with the only steroids, then the antivirals are missing in the picture, and you must do something more for the patient.
I think we've all encountered such scenarios, and most commonly when we talk about endothelitis and PBK, if it's a pseudophakic with an endothelitis, we are bound to get confused that we are dealing with the PBK. It is very difficult to get those very localized KPs when we talk about, and if you've done a DSEC or a DMEC in those cases, even after that you can always have a recurrence. I'll show in one of my cases that we didn't know. We treated it like a PBK, did a DMEC for PBK, and then after that had a geographic also. So it's sometimes after your surgery you realize, oh, initially also we were dealing with the viral. So masquerades in viral is very common. For endothelitis, yes, PBK becomes that. So most of the time, I think if it's a phakic patient, it's very clear. Most of us do give a trial of steroids before we think that, if you think that it's not exactly Fuchs, you think of viral endothelitis as one of the very common causes. But sometimes in pseudophakic, it is possible that you've missed. So it's not something which you cannot miss.
My first question is, as you have told, so how does the treatment of HSV and graft failure differs? Number one. Number two, did you encounter a case of endothelitis due to calotropis diabetica? Because in our sector, we are regularly getting, and they will not give the history of that fall. So our first question is, have you plugged that flower or not? Because treatment is different. And number three, in case of HSV endothelitis, where this separate, they are steroid dependent. The moment they stop steroid, again it will recur. So what is your take?
So a lot of questions were there. First part was Sumeet.
Yeah. So first was how do the treatment of rejection and the viral will differ. So it's basically when you have a viral endothelial lesion, steroids is a must that you are going to give. The systemic antiviral is missing, and in cases you need to start with the oral acyclovir, ganciclovir, whichever viral you are treating for the higher dose, and then accordingly treat the patient. The topical will not help here, the systemic will help. The systemic is must. So the second question was calotropis.
So calotropis, so those who have encountered that, they would know how to diagnose it. Typically toxic endothelitis, it's presents as the central corneal edema. You won't get any linear or diffuse fold that you classically seen in endothelitis, but the folds are like, whenever there is corneal edema, there will be descemet folds. So those folds will be like that. And of course the history. At times the clinical features are so overlapping, it must be some Shivratri preceding, or that patient must be a Shiv Bhakt. That is that. Yes, limbus, everything will be fine, only local corneal edema will be there. So that's a very important point. That's a very important point. You give you steroid resolve, but there is an article in Cornea. If you understand toxic endothelitis, some low grade inflammation do continue. Even if the immediately within 1 week everything resolves, but some low grade inflammation at the level of endothelium continue. So few physicians, they propagate a gradual taper. If everything is resolved, don't stop the steroid right there. Taper it over a period of 6 to 8 weeks for all cases of toxic endothelitis. Any?
I mean,
Yeah,
I also
so-
practice the same thing.
So third question was?
Third is that steroid. That I think you answered already.
Steroid depend, a lot of PGs are here. So there is a classic line in Krasmer's book which suggests a lot of patients of recurrence are primarily because you stop the steroid prematurely. Steroid has to be titrated depending on the severity. If the endothelitis is severe or endothelial edema is severe, you have to taper it over a period of 2 to 3 months, and tapering should start based on the clinical response. It shouldn't be like weekly once you are tapering, irrespective of the severity. So the starting dose as well as the tapering dose should based on your clinical response, not the diagnosis.
And sometimes even if you
Ma'am is going to cover that. Recurrence is there is a
no, I will be covering that. But when we are asking the question on that, whenever we are giving steroids, especially for endothelitis, where we know it's an immune component which is involved, and CD4 cells are the major cells which will again propagate and bring it back. So there, it has to be a very, very slow taper. So sometimes up to 3 months or 4 months, the steroids will continue on maybe once a day, and sometimes even after that you have to do that, because if you stop it, then the recurrence normally which comes back may also come back as a stromal necrotizing, which is something which you really do not want in those cases.
I think we are done.